Today on this episode of The Crossover, we will be discussing healing the brain with Harvard Professor Dr. Felipe Fregni. Learn how this pioneer in neuromodulation is pushing the frontiers of brain injury rehabilitation and advancing the treatment of conditions such as stroke, Parkinson's disease, traumatic brain injury, and chronic pain. Much more on this episode of The Crossover. Good afternoon, everyone. We have the pleasure of speaking with my friend and colleague, as well as a pioneer in neuromodulation. Felipe Fregni is professor at Harvard and director of the Spaulding Neuromodulation Center, where his NIH-funded lab investigates techniques to guide neuroplasticity in brain injury, stroke, Parkinson's disease, as well as chronic pain. Felipe holds an MD and Ph.D. from the University of Sao Paulo, Brazil, and 3 master's degrees from Harvard. He has more than 580 peer-reviewed publications and has been leading the international training program Principles and Practice of Clinical Research since its inception in 2007. We'll get more into that during the course of the interview. Dr. Fregni has also been awarded the United States Presidential Early Career Award for scientists and engineers. Very excited to talk to him today about healing the brain. Amazing advances have been made in terms of how we deal with these conditions of the brain injuries. And I'm very excited to hear what he has to say about what the future holds. So, Felipe, very excited to have you on. And again, thanks for joining us.
Thank you so much, Ricardo, to having me. I'm excited as well with our conversation.
Let's just get right into the details about what exactly is neuromodulation. People may not really understand exactly what that term means, but what does that encompass?
Sure, that's a great question, and that's one thing. So usually is one of my first slides when I give talks. So neuromodulation, it is, so there's 2 things. One, again, if you think of neuromodulation, it's a very broad term. It could be so anything. So we think of the modulation of the neural system, and then anything can modulate the neural system. So even now we are having this conversation, your brain is being modulated. When you do exercises, your brain is being modulated. When we study. So, but the field has used this term for modulation with electrical stimulation, with different tools as well that can deliver or can stimulate the neural activity. So that's how we are using the term. But in a way, again, if you wanted to go with the term, so it is very broad. But again, field is using more for electrical stimulation, magnetic stimulation, tools that can deliver currents to the brain or to the nervous system.
How did you first get interested in this field?
That's also an interesting question. So for me, actually, it comes even before going to residency in neurology. So I was very interested. So what can we do differently in neurology, in neurosciences, in order to improve patients' health and quality of life? As I was going through my medical training, during residency, for me it was clear that everything we are doing, so we're basically the model that we use, and most of our tools that we use in the clinical practice, at least again 20 something years ago, it was based on pharmacological approaches only, and a little bit on surgical approaches when it was possible. Even it's interesting because on the surgical aspect, neuromodulation was being used and tested for a bit longer. But going back here, so for me, it was clear that the pharmacological strategy had a limitation. So you reach the ceiling effect, or what you could do for patients, and then also you brought a number of complications, and that for me started sort of bothering me and getting me sort of impatient to find something else. So for instance, Parkinson's disease, yes, there is all these sort of treatments with dopamine agonists, but they have a limitation on how much you can improve it, and also it comes with all the complications as we can see with pharmacological treatment for Parkinson's disease. But then it was interesting. So then during my residency, I came here to Beth Israel. It was supposed to be 1 or 2 months actually for an observership. and that's when I run into, there was a 2000, I run into the laboratory of magnetic stimulation, and that gave me sort of I was looking for, in terms of, that's something that it is an alternative to pharmacological treatments, and also that goes along the lines that I was looking for. So can we use our brain sort of a response, our brain mechanism, in order to overcome or compensate for the consequence of brain injury or brain disease? And that for me, actually, there was a click when I was exposed to this laboratory of TMS here at Beth Israel. And then I finished my residency, and then the day after I finished my residency, I was coming to Boston. Literally, actually, I think there was 1 or 2 weeks I finished my residency and I was in Boston. Then and that has been sort of my journey here, trying to find different tools and understanding so that we can offer better treatments.
Now, I think, people want to know, because the brain is unlike other organs in the sense that neuronal regeneration and neuroplasticity is limited as opposed to bones or skin. How do you overcome that limitation in regeneration that the brain presents?
Sure. Yeah, that's another important topic as well. So the way I see it, and that's when actually when you don't get the expected results what patients wanted. And so one of the issues of neuromodulation, as you are using plasticity, as you are using sort of the mechanism, I like to call the healing mechanism. So in a way, it is our compensatory mechanism. So as you're using these natural process or physiological processes, it takes some time. You're not going to have the immediate effect that, for instance, taking a dopamine agonist will give to you. So it requires time to develop these new connections, to strengthen the connections that you created. And so that's the response. So it takes time and training and effort. So if you wanted to do, and that's one thing that we start seeing. So the initial protocols with TMS, for instance, it was 10 days, 5 days, stop on the weekend, and 5 days. So then we start seeing that then 10 days is not enough, and you need 15 days, and you need 20 days. And now we're even seeing that it's better to have a maintenance protocol. And that for me, and it makes a lot of sense. And one thing that we're even exploring now, not only the number of sessions, but having longer sessions with portable devices. So the brain needs constant stimulation, and that's where we need to adjust to be able to offer something that will have a larger effect sizes, because it's all about effect size. So it does have an effect, but we need to enhance these effects. And that's also one reason that we see better results with surgical neuromodulation, where you put the implant, because you have that stimulator for a continuous amount of time.
Now, something we see in surgery is how age-dependent neuroplasticity is. You operate on a younger patient, and their ability to recover from deficits produced by the tumor or by surgery itself is much greater than the ability to recover as they get older. How age-dependent is neuroplasticity in your experience?
Sure. So we have run, and that's one thing that we looked into in most of our studies. So, when we finish the study, we see a significant result, but the next question is, what are the characteristics that patients respond more? And we run regression models, these statistical models, to try to find the factors that influence the response. And we've seen that age is an important factor. However, it is, and it's not at the same time. So let me explain. So it is significant, but the effect size is small. So meaning that, yes, you do have it when you compare the sort of a younger to an older brain, you do have it a larger effect in the younger. But what we've been seeing is that the older brain needs a little bit different parameters, and same thing as well, needs a little bit more stimulation as well. So the younger brain may respond with a smaller dosage of stimulation, and the older brain may respond with a larger dosage. But again, in rehabilitation, in neurorehabilitation, and that's one thing that sometimes we see this sort of old neurologists saying, "No, look, your learning and your plasticity would be limited," and that's not what we see. It is different, true, compared to younger, but you still can induce a significant plasticity in the older brain as well. So that we just need to learn more, and I think that's most of the studies we do that's the problem as well. So now we are pushing to have more studies in older people, but that's one of the problem with the data. So our data is mostly on adults.
This episode is brought to you by Vitamin Water. Vitamin Water contains the optimal blend of electrolytes to fuel your day. So whether it's doing brain surgery or simply relaxing at the beach, Vitamin Water should be your source of hydration. Check out vitaminwater.com for more information and use promo code CROSSOVER for 20% off your first order. That's CROSSOVER for 20% off. Now, you've mentioned already some examples, but give us some more information. What are some of the tools that you use to neuromodulate the brain and augment neuronal regeneration?
Sure. There are different tools. Even before going there, so one thing that I will even anticipate one important question is that, if you ask, so which one is better, or what is the best one? And that response we don't know yet. But then I think the main or the main sort of category, sort of, let's put it sort of the category here, it is the electrical stimulation and the magnetic stimulation. So meaning you can induce electrical currents directly with electrical currents. So, or you can use magnetic stimulation, but the magnetic stimulation, that's an important concept. The idea of using magnetic stimulation, it is to induce electrical currents. So we use a varying magnetic field that causes a electrical current, induces a secondary electrical current. So that's the idea of using magnetic stimulation. At the end of the day, you want to induce electrical currents, electrical activity in the nervous system. So with that division, so again, one main tool is the magnetic stimulation, transcranial magnetic stimulation, that basically uses magnetic stimulation. The advantage of magnetic stimulation is that it induces a large amount of current into the brain. So that is relatively painless. So, and then it can pass the skull without any difficulty. So the only problem with the magnetic field is that it decays with a square of distance, meaning that you can't go too deep. So most of the effects are in the cortex.
Gotcha.
So that's a good tool if you wanted to induce larger electrical currents into the brain. So we can see as well. So for instance, you place your TMS on the motor cortex, and we see the hand twitching. You see, meaning it's a large electrical current, and then you can use this in several areas. You can use the motor cortex in stroke, in Parkinson's disease. A main one that was, since the first studies, even in the 90s, it was with depression. So using TMS on the prefrontal, DLPFC, dorsolateral prefrontal cortex, and showing good results. So, and it has been used, TMS has been used for a number of conditions, epilepsy, chronic pain, and so on. So again, but being careful, because induce a large current, there is a small risk of inducing seizures depending on the frequency and intensity of stimulation. So that's and also you need the large device. It is not portable. There is one device that they approve. I think they approved. It's the FDA approved for portable. It uses a large magnetic stimulator, and it just delivers one pulse for migraine. But that even the efficacy is still being investigated. But most of them, you need to go to a treatment center, receive it, need to go to the hospital or whatever treatment center. And then you have the electrical stimulators. Big advantage is that they are easier to use, more portable, and also in a way safer because they induce a smaller amount of currents. And then, and again, the one that we are excited, and the field has produced so much research, is with it's called transcranial direct current stimulation. It uses a continuous or one direction current. So when you do that, what happens? You have it. If you put the two electrodes here, you have this difference of potential between two electrodes. That means that you're going to have a ionic current, and you have to have a polarization in the brain. This technique was called as a brain polarization. We changed the name when we started doing more research in 2000, myself and also Michael Nietzsche from Germany, to transcranial direct stimulation. But the papers before this, let's call new era of TDCS, was called brain polarization. It caused a polarization. And again, it's safe, it's easy to use, it's portable, and the idea, it causes we say it causes a difference on the neuronal threshold, meaning that neurons can fire easily or not, or less, or it's more difficult to fire. Therefore, it is good that when you combine with behavioral therapies. So those are the tools, and then there are more tools, but one that is being now, and we are doing a number of investigations on that as well, on transcranial or transcutaneous vagal nerve stimulation. So the vagal nerve seems to be a large access to the, especially to more subcortical areas, to the brainstem and the limbic system and so on, and even cortical areas. So it seems that the vagal nerve has an important modulation effect on cortical and brain structures. So, and it's easy to access through the ear. You can do the neck as well, but you can through the ear. And the surgical field, as you know, so has been using vagal nerve stimulation invasively for many decades. It's FDA approved and so on. So I would say those are the techniques. There's some variation, some using magnetic stimulation with low magnetic fields. And then the data is not, it's a little bit mixed at this point, but those are the main categories. So either nerve electrical stimulation, or brain electrical stimulation, or brain magnetic stimulation. So that's
very cool. It's such exciting technology. Give us some specifics, right? Because it's kind of nebulous for the general population, but how are you using them to augment recovery after either traumatic brain injury? How are you advancing Parkinson's disease potentially? And what about chronic pain? These are all conditions that really could benefit from this. Give us some examples.
Sure. So for and I think that's we can even divide here. So one is when you have a brain lesion, let's say a stroke or traumatic brain injury. Traumatic brain injury is a bit more complex because each injury is different in terms of what damages a stroke. True, that is also different, but it has at least some vascular territory. But thinking on there is a lesion in the brain, so there's one area that's affected. I think the whole idea of plasticity, and that goes back to the Spanish neurologist Cajal, is that all the areas of the brain they changed in a way, and you start developing new connections as well with intact areas. So there's a lot of redundancy in the brain. So that's one interesting aspect as well. So the circuits, as we go to the learning stages, of course, the circuits get more specialized, but you still maintain sum of redundant circuits. You just need to reactivate them. And that's the whole idea. So, and that's what we do. We try, for instance, and one thing, there's two things that happens. So one, trying to get these circuits again, and two, trying to avoid what we call maladaptive plasticity. An example, let's say, again, you have a stroke and you have a weakness in the left side. So what's going to happen naturally, you're going to use more the right side. And then by compensation, your healthy hemisphere, brain hemisphere, it's going to inhibit your affected hemisphere. So that's what we call maladaptive plasticity, meaning that you wanted to shut down even more the area that was affected. And when we try to do it, we try to decrease activity in the good hemisphere to try to force whatever is intact in the lesion hemisphere to take over. So, and in a way, it's what is being used in physical therapy, the constraint movement-induced therapy. They do that, but they do that by blocking the good hand and forcing the affected hand. So, but we do this centrally, and that's the idea. So again, is trying to enhance activity in the areas that is still, you have intact areas that can be used, and force those areas to develop new connections. And we're still learning which areas should we go. And again, and the idea also now is, as it gets easier to do neuroimaging subjects, as it gets easier to understand what's happening on an individual basis, then hopefully we understand more which areas should we turn on, let's put it this way, and which areas should we turn off when you have a lesion. So that is the whole idea, but always and associating of course with motor therapy and so on. So, but that's the idea for again stroke and traumatic brain injury, trying to enhance those areas that still have some intact neuro connection. So, and then that's when you have a lesion. And when you don't have a lesion, for instance, chronic pain, which is quite interesting. In a way, chronic pain is always something happen with your sensory pain system. Sometimes it's not a big lesion, but even a small nerve lesion. For instance, in fibromyalgia, we think, now look, fibromyalgia is a more psychological issue and starts with depression. But more and more, we see that in fibromyalgia, it is quite similar to neuropathic pain. And it does see in these patients, they have what we call small fiber neuropathy. So they do have some changes as well in the sort of the small fiber nerves. So and so what I'm trying to say is that usually, even though there's no large lesion in chronic pain, there's always something that is imbalancing the whole functioning of the sensory pain system. And when that happens, for instance, some nerves, some peripheral neural areas started to produce less signaling to the brain. What happens is that the brain reacts to that. So look, if we're not getting all the sensory afferents, all the sensory information from the periphery, what will do it, the response is you make those systems more reactive, and that's when you start seeing hyperalgesia and so on. So the system starts to react, but the problem is that it doesn't react only for that small area that's lesion, for the whole sensory system. So then, before what was not painful becomes painful. So that leads to central sensitization, peripheral sensitization. But again, it's always a dysregulation of your sensory pain system. And then what we try to do it, that's the quite interesting part. What we try to do it is we stimulate the sensory system instead of decreasing and that goes exactly opposite for the opioids. We do exactly the opposite. Opioids try to shut down everything. That's why, again, you have the dependence, and you need to be taking more and more, and develop all the consequences. But we do the opposite. We don't. We cause more activation on the pain system, on the sensory system. So then you can develop your inhibitory pathways, your normal endogenous inhibitory pathways. So that's, again, and that's why I'm so excited with neuromodulation, because we try to use our brain compensation systems, and we have many. We're just not exploring that. And again, and the traditional pharmacological therapy of very, very useful, but they go against that. They go against this natural compensatory mechanism. And for instance, opioids is an example, analgesics an example as well. So because what happens is that you keep decreasing your sensory processing, and therefore you keep decreasing your endogenous inhibitory pathways, and patients keep getting worse chronically. And for acute, that's fine, but for chronic use, that's what caused all this, and we see now with opioid crisis and so on.
Now, something that I'm sure has played a role in your research is the field of Conatomics, which is exploding. How are you incorporating this new technology and information into your research?
Yeah, that's another very important point as well. So I think that's so much. So I think that's how. So we haven't doing anything specifically on that. So we do it in a more sort of we do it in our studies. We look for connectivity in different ways, and I think that field is helping us to identify the circuits. So I think that's what's helping us to, as we understand more the circuits, and because that's a difficult thing on thinking on brain stimulation. So if you try to change excitability in one neural circuit, this has a whole consequence to the brain. So different areas get affected, and we still don't know. So the mapping is still not completely understood. So in a way, again, what I'm trying to say, it hasn't translated fully to be able to understand even better the what we need to do it in terms of parameters of stimulation, so on. And so again, we keep the most of the studies, we look for connectivity with different tools, but it's still sort of also one thing that's important is the resolution of these tools. It is much lower than we would like to, and the brain is extremely complex, so if you think on the electrical circuit of the heart, it's quite simpler compared to the brain. And so again, I think it still hasn't changed fundamentally, but of course it does have a big influence as well on how we think and how we're looking for developing novel treatments. Yeah.
Now, two areas that I think have a lot of potential interaction with neuromodulation would be stem cells and then brain-machine interface.
Sure.
Are you incorporating those in your lab at all, or what's your opinion on those two fields?
Sure. So this stem cells, we have not. I think the results. So the stem cells. So the field has had mixed results in terms of the stem cells and what can be done as well. So I follow some of the research in stroke, some animal studies with good results, other with a little bit unclear results as well. So, and in humans, it hasn't been very clear as well. So potentially, I could see if we show lock stem cells, you can enhance plasticity in the sort of in the surrounding of the lesion area, for instance, in this gray area there that you have it in a stroke. And that's what they're trying to show. Again, some animal studies showing good results and these mixed results. But let's consider that stem cells, and you can truly get the cells located on the lesion areas and they start becoming active. Then you'll be a great component to be associated with neuromodulation. So then you can use neuromodulation, you enhance this activity in this area, can even help to make the stem cells to become another circuit. But it's still, again, I haven't seen too much to be able to design a trial and say, look, let's test together. Maybe a few years from now, you start getting a little bit more robust data that we can. I think it's a potential. That's what I put it there. And then on terms of machine learning and the brain-computer interface. So the whole idea of this closed loop system that you detect information in the brain and then try to modulate, change the parameters of stimulation. We've done some studies. We still need to learn more. So most of the studies we've done as well is all non-invasive. So we use EEG for the brain-machine interface. So we use EEG. This EEG signal goes to the stimulation and then triggers the stimulation when you have it, let's say, a decrease in activity. So then it triggers that. We saw good results, but it's still unclear if that now with the knowledge we have it does produce a significant better result. But I still like this approach of combining both signaling, measure the signal in the brain, and take it to the stimulator, and then trying to use that to modify activity. So I do think that's a potential new area as well to be explored more as we learn more in terms of what does that mean. This we still need, again, going back to what we discussed, we still need better resolution tools or understanding better the signal. So the EEG, there's so much to do in EEG as well to understand more novel parameters of EEG and how to use that to guide the stimulation. But that's an area that hopefully there'll be a good development, and also to have more portable devices. So
now let me ask you a little bit about your novel Harvard program on clinical research training. You've been such a pioneer in the field, and this training program has so much potential. It's really already blossomed. But tell us a little bit about what that program entails.
Sure. Yes, we are. I'm very excited with this process. It's another big passion as well. Besides of my research, I think that those are my two main areas here at Harvard. So that comes a little bit about my trajectory here as well at Harvard. So when I got here, I got my training at the University of Sao Paulo, and then I got here. So again, as most of clinicians, and I can see the clinicians here from Harvard as well. So we are not exposed to as a clinician. So you get very little exposed to good training in clinical research methodology. There is something here and there. Maybe also the students and residents are not that interested, and there's a mix of components there. But anyway, for me, when I finally took it, I came here and then I took a program at Harvard School of Public Health. That was the first master's, and made a big difference. And because it's not, when you become a scientist, it's not only learning about everything on neurology or neuroscience, but you need to learn the methodology, so then you can design your trials and so on. And if you're a clinician also, and that's one thing that I pass to the students, if you're a clinician, as much as you learn about data and evidence-based, not only to read the abstract, but you can go deep on a paper that is important for your area. So that would change how a clinician can perform. That's at least for me, it's very clear. So then, but then going back there, so I had this training here at Harvard, and for me again, and I was going back and forth, traveling to Brazil, other places in South America, research collaborations and so on, and my colleagues asking, so can we, how can we increase the collaboration and training? And that's when I came back, one of these trips, I came back here to Harvard, and I discussed with colleagues. I was a junior faculty at that point, and I discussed with my colleagues, so can we do a program initially was with colleagues in Brazil. And anyway, after all the hurdles and so on, we said, let's do a program. Initially was meant to be 1 week or a few days. And I said, look, we need to do something more longitudinal. And that's, at that point, of course, there was video conference, and was much, much more difficult. Now with Zoom, everything's so easy. But that point was, to get what we're having here, you need very expensive devices to have the same quality. You could do web connections. We started in 2008. You could do web connections. There was WebEx. That was the main one at that point. But it was terrible. So to get a web connection, you would have, I speak, you close your microphone, and I stop speaking. It was, those systems, that's the only way not to have echo. And the camera as well, we have to speak, turn off the camera, even with 2 people. Anyway, so, and the bandwidth, but we managed with this more sophisticated equipment. I remember I had to go to a basement in Brigham and Women's Hospital to be able to have a good equipment and then do the lecture with Brazil. But that's when we started 2008, and the idea was, can we deliver a high quality program almost over a year to a global audience? We do have it here in Boston, about 40 students, but that was designed to be and trained with a sort of high quality education for clinicians, for those who wanted to become scientists, or for those who wanted to become better clinicians. And then we cover all the aspects of clinical research there: clinical trial methodology, experimental trials, and then we also cover observational trials, statistics. They learn about even using statistics. Stata, we use one of the statistical softwares. They write papers, they publish. Because of that, 8 years ago, we created a journal, a peer-reviewed journal. That was the same name, PPCR journal. So, and truly to give them the opportunities. Passionate, because can we try to, at least to decrease this inequality, this important inequality, between scientists and training in US, Europe, someplace in Asia, and then compared to South America, Africa, and so on. So far, again, we are in this 16 year of the program, and just growing. So we now have about 500 people per year, but we still can keep a high quality education even with this large number. It's intensive. There's a number of TAs. We have almost 200 TAs, teaching assistants in the program. So it is a large sort of a program, and I've seen the results. So that's why I'm very excited with this, and seeing as well. It's great to start seeing those who took the program, and then some of course that come to US and having good careers, and it is great to see those results.
What an incredible initiative! You should be so proud. I just want to wrap up, just because we're running out of time here, but give us your crystal ball view as someone that's a leader in neuromodulation. What do you think is going to be the #1 breakthrough that we're going to see in the next 5 or 10 years?
Sure. So, what I think the breakthrough, and I think that's very much needed, is to have very portable devices. So that is going to change the field. The field hasn't let's say, hasn't had this breakthrough because of the lack of portability. And I remember discussing 15 years ago with some companies they're asking for advice, and I say, look, there's everything for the field to go and improve and enhance the use as well. But portability is a problem. But then now I see sort of a more stronger movement according to that. So if we can, for instance, so having in a phone, same thing on the a small device you can put in a ear, for instance, vagal nerve stimulation, and you can push a button, and then you are being stimulated, and according to a measuring, stimulating. Then you start having something that's as easy as taking a pill, and patients will start using more. So that would be the breakthrough that is much needed. So then stimulation can be part, neuromodulation can be part of the tools of any clinician. So hopefully that'll be what will change the field.
Philippe, unbelievable interview. You should be incredibly proud of not only that training program, which is allowing scientists across the globe to benefit from what you're doing, but just your research initiatives to understand the brain. And like I said, the brain doesn't have the healing capacity like other organs. And so your guys' advancements really have the ability to change the way we treat stroke and other chronic diseases like chronic pain, Parkinson. So very much look forward to seeing what the future holds. And again, congrats on all of your accomplishments. Very impressive.
Thank you very much. It was a pleasure. So anytime and anything, anyone who wants to connect, I'm always very happy to follow up. Thank you very much.
All right, Philippe. Take care. Have a great weekend.
You too. Take care.